Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, this is Alan Gassman, and I have our guest Lester Perling with us here, and it is Tuesday, December 27, 2011 at 5 p.m., and we want to welcome everybody. We did send an alert out to our physician clients last week about this new law as to registering as a pain doctor, a doctor who prescribes pain medication for chronic non-malignant pain. We're going to answer your questions today about that new statute, and we're also going to review the pain, controlled substance, and prescription rules for physicians. Thanks for joining us. Whatever your questions are, please feel free to email them to us now or after the presentation, and I'll just go ahead and go through this outline. I'm sure you have the outline in front of you. You should be seeing it on screen. You see Dr. Singh's picture there also. He'll be joining us to make a few comments also as well. Now, you also did receive an email with our booklet, which will be finalized next month, which is called the Florida Physician's Guide to Prescription and Controlled Substance and Pain Medicine Laws. If you want the update to that when we come out with it, just let us know. Okay, tearing into the PowerPoint now, I just want to point out 8 mistakes in 8 minutes, and I'm going to probably even point these out in faster than 8 minutes here for everybody so I can leave more time for Lester. But the biggest 8 mistakes we think under these new rules will be: 1, failure to use the standardized counterfeit-proof prescription pad rules. 2, and then we're going to talk about this a lot, failure to register as a controlled substance prescribing practitioner. Your deadline is December 31st, so you don't have much time. And that applies if you are a physician who is prescribing medication for chronic non-malignant pain. So we're going to cover this later, but what is chronic non-malignant pain? This is pain unrelated to cancer, not rheumatoid arthritis, which A, persists beyond the usual course of treatment of the disease or injury that causes it, or B, persists for more than 90 days after surgery. So if your mother-in-law calls you and she is past the usual course of disease or injury, or she's beyond the 90 days after a surgery, and she asks for pain medication, you can't prescribe it unless you have registered with the Department of Health as a controlled substance prescribing practitioner. Welcome, KB Lee. I'm glad to see you here. Okay, now the third mistake is failing to satisfy all the documentation and standard of care requirements when you are prescribing chronic non-malignant trained controlled substances. We'll be covering that as well. The fourth mistake is failing to satisfy the additional medical record documentation requirements when you're treating any pain. That's not only chronic non-malignant pain. These are the long-standing regulations that many people haven't worried about, haven't known about, but now with law enforcement becoming very active, physicians are going to want to follow these rules. The fifth mistake is dispensing Schedule II or Schedule III controlled substances beyond the exceptions allowed for them, which you can read on your own and which we'll cover in a few minutes. The sixth mistake is failing to register as a dispensing practitioner if you dispense these controlled substances for direct or indirect remuneration. In other words, if somebody's paying you for these substances. The seventh mistake is failing to register with the Prescription Drug Monitoring Program's electronic database, eForce, and we'll talk about why you would want to register with eForce and how important it can be for your practice and your patients. And the eighth mistake is failing to register as a pain management clinic if you have to. Now, you may not have to register as a pain management clinic even if you're registering as a controlled substance prescribing practitioner. So we're going to be talking about that as well. Now, the next page of our PowerPoint, page 3, I want to just talk about the 9 separate rules, because there's 9 separate rules and everyone gets them confused. We're going to take these rules one at a time tonight, but we want you to know what they are so it's easier to follow us. The first is that everyone has to follow the prescription pad rules, and most all of you are aware of this rule and what it means, but we're going to cover it. Secondly, you have your federal DEA requirements. We have found that a lot of medical staff are not aware of the difference between the federal DEA requirements and the controlled substance prescribing practitioners requirements. The federal DEA requirements are, of course, the federal government, and the controlled substance prescribing practitioner requirements are the Florida rules for doctors who prescribe chronic non-malignant pain. Fourth, the administrative regulations that all MDs and DOs have to follow. We have these here for you and also in the booklet that we have sent you today. Number 5, the registration and requirements for all physicians who dispense controlled substances. Number 6, the new eForce program, which, as I said, you're going to want to know about. Number 7, the pain management clinic registration requirements. And if you're not a pain management clinic, you may want to become one, because the clients who are complying with these rules and who are receiving a lot of referrals for well-meaning patients from well-meaning practices are finding this to be profitable. Number 8, the burglary and theft crimes involving controlled substances. And number 9, just so you're aware of them, the tremendous pressure that pharmacists, pharmacies, and drug distributors are under. Now, on page 4, we have the general definitions of controlled substances and chronic non-malignant pain. And my co-presenter here, Lester Perling, who is definitely the brains behind our operation. Lester is a board-certified healthcare lawyer with the Broad & Cassell firm in Fort Lauderdale. He is just getting over a sinus infection. He's in New Mexico on vacation, and he was kind enough to join us today. Lester is a law professor also, teaches health law at the university down in Fort Lauderdale, and is a former chairman of the tax section of the healthcare section of the Florida Bar, and also just a great guy. So Lester, welcome.
Thank you, Alan. So let me, in terms of the definitions, what we're primarily talking about in terms of a lot of these statutes and rules are Schedule I and Schedule II drugs, which are the drugs that, Schedule I are the drugs that nobody can prescribe for essentially any reason other than marijuana, perhaps in states that use medical marijuana or permit medical marijuana. Schedule II, though, is the schedule where we find most of the pain medications like oxycodone that have the strongest potential for abuse and probably have the greatest level of concern among law enforcement and the legislature. Schedule III follows closely behind that. While they have less potential for abuse, they also have potential for abuse. And the Schedule II and III drugs are really the most regulated drugs under the more recent changes to the law. Schedule IV and V are also controlled substances. They generally have a lower level potential for abuse and are not receiving as much attention, but still fall within the general category of controlled substances, so some of the new laws apply, even though they may have somewhat lower abuse potential. All right, the definition for chronic non-malignant pain, Alan kind of read that quickly. I think that the key part of that the definition rather, is in B, which is kind of a little bit the catch-all, and when we talk more about the controlled substance prescriber registration requirements, we'll get a bit more into this. But that's going to, basically, that B is going to consume an awful lot of prescriptions, but not necessarily all of them. And we'll talk more about that when we get to the registration requirement, Alan.
Okay. Let me mention also the booklet. I'm just going to move it onto the screen here. But the booklet at page, and I'm sorry, I'm having a technical problem. But the book has all the Schedule I, Schedule II, Schedule III, Schedule 4, 5 substances for everybody's reference.
And one point here is keep in mind that a lot of physicians apparently, when they think of controlled substances, they tend to think more of narcotics. There are a lot of drugs that are commonly prescribed that are controlled substances, at least under perhaps Schedule 4 or 5. So you do need to be careful with regard to verifying whether a drug is in fact a controlled substance or not on the schedules that are in the book or available online.
Okay. So should we go ahead and go through the rules having to do with prescriptions?
Sure. One obvious point, or should be obvious point, but sometimes isn't so obvious, is security of prescription pads. They need, and this isn't new, this has always been the case, but unfortunately a lot of physicians still have problems with this, is just keeping control of your prescription pads and not leaving them laying around in the exam rooms, which I've seen, even in a nurse's station in your office that isn't where there, it's no one sitting 100% of the time, because patients may walk by it and see your prescription pad sitting there. They need to be locked up or sitting or secure in your pocket and not sitting on anybody's desk or in any exam room ready to pick up and be used, because you are responsible for the security of those pads, and you may not know that someone's stolen some of the sheets out of your pad for quite some time, but it can come back to bite you in the rear. If you're aware that prescription pads have been stolen, or even sheets out of a prescription pad have been stolen, we recommend that you file a police report. You're also required to notify the Department of Health. But that way it's on record, so when those prescription blanks show up having been forged and there's a prescription for some highly unusual amount of some controlled substance, you will have been on record as reporting some blanks or a pad having been stolen, as opposed to perhaps this is something that you have done. One of the changes is, and that's true too in terms of security if you prescribe electronically in terms of your password and whatnot. In terms of the recent changes, one of them, as you probably know by now, is that you have to use counterfeit-proof prescription pads, and the list of vendors are available at the website that's on your screen, and I know that's in our book. And there may be some more changes coming with regard to prescriptions, as are in the note there. In this coming legislature, we'll have to see. It's way too early to know what this legislature will do or won't do, but we certainly would expect that there's going to be some more activity in this area as they continue to try to tighten down.
Okay. Should we go ahead to the DEA requirements now?
Sure.
Okay, so slide 2, just to mention the DEA, so that we know it's separate and apart from all these other rules.
Yeah, I mean, the DEA requirements, of course, any prescriber has to have a DEA certificate, and I think everybody knows that and has one. Not many physicians are necessarily aware that there are a whole set of regulations, and there are federal statutes and federal regulations that govern the use of controlled substances, and they all, while they come into play perhaps in your everyday life, you should be aware of them because they have been used to prosecute physicians where the federal government believes that the physicians are improperly prescribing in one form or fashion or another. I mean, these are typically the more egregious examples where physicians are outright selling prescriptions or pretending to do exams when they're not. However, there's also more detailed requirements, so it would be a good idea to look at the website that is on your screen there, just to get an idea of the types of things that the DEA regulates.
Okay, and then there's more information in our book that you're welcome to look at. But let's go now to the reason that most people are watching this, and that is this December 31, 2011 registration requirement for the physicians who are going to treat chronic non-malignant pain.
All right, this is one of the bigger things that came out of the last legislative session, and it is the deadline to register, if you have to register, is this week, December 31st, which I think is actually Saturday, so Practically it may be Friday, but I assume the website's available for registration. There's a lot of questions in physicians' minds thinking that, well, I want to avoid registering because I think that registering somehow could be a bad thing for me. And while they can't necessarily vocalize why that is, it's just sort of a distrust of adding your name to another government registry, if you will. And that by being a registered as a controlled substance prescriber, you might come under more scrutiny than you would if you were not registered as a controlled substance prescribing practitioner. That may be true. I mean, obviously, your name is out there as someone who prescribes these drugs, and so there's always the potential for the Department of Health to come and look at what you're doing in that regard. However, if you don't register, and you should have registered, and the Department of Health becomes aware of that in some way or another, you probably are in for a greater problem than if you did register, you were doing things correctly or pretty close to correctly, and they did come and take a look at you. The fact of the matter is the state's going to be monitoring your prescribing patterns anyway, and we'll get into that when we talk about the E-Force, or the Controlled Substance Dispensing Registry. So the government's going to be looking at what you are doing in terms of prescribing controlled substances, whether or not you register. Let's talk a little bit more about what I alluded to earlier with regard to the definition of chronic non-malignant pain, particularly that segment of it that talks about beyond the usual course of the illness or injury. If a patient comes to you with if you're a primary care doc and the patient shows up with a sprained ankle, and let's say it's a severe enough sprain, the patient's in enough pain that you feel like writing a controlled substance, something more than Advil or Tylenol is in order, and you write, a 5 days worth prescription, no refills, and you never hear from the patient again, that's clearly going to be within the usual course of the patient's injury, no problem. But let's say that same patient then comes back to you a month later and says, oh, doc, I still have this pain in my ankle. And, the x-ray was negative for a broken bone initially, and you decided it was just a sprain. But now, well, maybe there's some torn ligament or something that wasn't viewed on the x-ray, and you order an MRI, and the MRI is negative. And now you start thinking, I wonder if this is drug-seeking behavior, or maybe the patient has pain objectively, subjectively in that patient's mind, and they're not just seeking drugs, but it's probably beyond the usual course of the injury. And if you asked any doctor out there, they would say, yeah, you shouldn't be having pain with a sprained ankle a month later when there's no broken bone and there's no other anatomic damage visible even on an MRI. So if you're going to continue to write a controlled substance for that patient, you better have registered as a controlled substance prescriber, because now you're outside of the usual course of that patient's, in that case, injury. But let's say you're, and this is a question for some reason it's come up 3 or 4 times, you're an endocrinologist and you treat a lot of diabetics, of course, and those diabetics have peripheral neuropathy. And I gather a lot of endocrinologists, when it comes to the side effects of diabetes, are kind of the patient's primary care physicians and tend to treat those side effects, which might include prescribing controlled substances to control that pain. Now that's a lifelong problem. There's no cure for diabetic neuropathy, as I understand it, and so there's going to be an ongoing need to prescribe medications. Now, the endocrinologists I talk to tell me that really any time that if the patient is diabetic and they have diabetic peripheral neuropathy, and that's diagnosed and objectively verified, however that's done, then the usual course of that illness is until the patient dies, at least until there's a cure for diabetes. So there's a good argument then that if that's all you're prescribing, you never have to register. But again, let's say that diabetic patient comes in to you with a sprained ankle. We're back to that example. well, now it's a different story. So you really have to think about your practice and the patients you've treated over the past year and what you have done for to kind of figure out, okay, do I need to register? I don't really see a harm in registering, despite the fact your name goes on another government list. It's better to have registered than not registered when you needed to register, because they will know when you prescribe these controlled substances because they're going to be in a different data bank. And so they may be able to tell that you are now registered and you should have.
It's a no-brainer to register for sure. I mean, I don't have any hesitation that you have to register. Also, I'm very sure that there's so many doctors registering that they're not going to have time or the ability to come and look at everybody who's registering.
Absolutely. Absolutely. The other thing, some doctors are saying, well, I just won't register, and if I have a patient that needs those drugs, I'll refer them to a pain specialist. That could present its own problem. Number one, it's going to be a PR problem because, if I come to you with a sprained ankle and you can't prescribe something for me, and you say, well, you have to go see Dr. Smith, who's a pain specialist, and it's going to take me a week to get an appointment, you're going to end up causing me to go to the emergency room, which really isn't appropriate from a utilization perspective. And I'm going to be very annoyed with you, and I'm probably going to look for another doctor. So that tact has been brought up by several physicians, and I don't like it. I think you're not, arguably at that point you're not practicing within the standard of care because you're afraid to register, so you're not really treating that patient as you should. They really aren't suffering from chronic pain. Do they really need to see a pain specialist when they have an acute injury or illness? And I think it's a bad PR move as well to take that tack and just say, I'm just going to refer all those patients out to somebody else. I think in the long run, that's a bad choice.
Okay, should we go on to the exceptions now?
Sure.
Okay, so section 3.1 on page 8, we have the exceptions to the registration requirements. And the first thing I want to point out is there are many different types of physicians who have certain exemptions under other rules, but not under this rule that we're talking about. Just because you're a board-certified anesthesiologist or a physiatrist or a neurologist or you have surgical privileges does not mean that you don't have to register under this rule. If you're going to prescribe any chronic non-malignant pain medication, then you have to register. The second thing that we wanted to point out that Lester's been asked many times is if you're prescribing Xanax or other similar medications for anxiety but not pain, those aren't counted as pain medications. If you document your chart that you're prescribing this for anxiety or for something other than pain, then that may not cause you to be within the realm of this statute.
Another gray area there that probably will depend on your documentation is something like prescribing Ambien. You have patients who have pain, and you give them Ambien because they can't sleep at night because of the pain. Well, the Ambien isn't doing anything theoretically for the pain; it's helping the patient sleep. So, if you're not registered and you're not within the usual course of the illness or injury, let's say that's an acute injury where it wouldn't matter anyway. You need to document that you're treating the pain. That you're treating the insomnia, not write about pain, but that's just that the patient is having trouble sleeping. So in part, it's going to depend on how you write your note, as so many other things do.
Right. Now, the other exceptions, and I'll just go through them here if you follow the cursor, obviously pain medication for cancer is not covered under this rule. Pain medication for rheumatoid arthritis is not covered under the rule, but other kinds of arthritis are. Pain treatment during the usual course of the disease or injury is not covered under the rule. Hospice-bound medication is not covered under the rule. And then the post-surgery medication is not covered under the rule if it is for up to 90 days after the surgery. And of course, the prescription has to be in 14-day or fewer intervals, so the patient needs to come back every 2 weeks to get renewal of that prescription. Any comments on that, Lester?
No, other than that exception there is going to cover for surgeons, that's going to cover them probably, if not 100% of the time, close to it, since most surgeons that I know of, if a patient has chronic pain after the immediate post-surgical procedure, they're not going to treat them anyway. So to a large extent, surgeons sort of are going to get a pass on this, but again, need to be aware of, Alan likes to use the example, if you prescribe something for your mother-in-law, once you do that and it's not within the usual course of illness or injury, or it was fitting in some other exception, just because you're a surgeon doesn't make you exempt.
Okay. All right, so if you're in these rules and you are writing prescriptions for chronic non-malignant pain that's not accepted here, then you do have patient record documentation requirements, and this is the real price that you pay. But keep in mind that these patient record requirements are requirements that you may want to put into your medical records anyway, even if you're treating something that falls within the chronic non-malignant pain. And we've had Dr. Singh join us here. Dr. Singh, are you with us?
Yes, I am. Hello there.
Excellent. Hi. Hi. Well, we've been talking about these pain medication rules, and we've just started. It's perfect that you've joined us now, because we're on this screen on the record-keeping documentation, and you've done a great job in your practice, what we've seen with the protocols. Do you want to maybe give us just a few comments now on how this has come together for your practice, and then later on in this webinar we'll have you comment towards the end on how to sort of sum this up for the doctors who are listening.
Yeah, I think one, which is actually your list here, is wonderful, the 3.2 patient record documentation. It really points out everything that should be done. We have made a checklist, and so anybody with pain who comes in, and even hospitals are using it, what's the intensity of the pain, nature, all the prior treatments. And the key really is about documentation, what all you can easily write down and just follow up, making sure patients get all the educational material. Important thing is to document the severity of the pain, the attempts to taper off the medications, the self-questionnaires, the drug screens, any objective evidence you find. One thing that I've seen a lot is the prescription pads. You have to make sure you have to really account for them as if you're handling. I like to think of handling the prescription pads as if they are your cash. Put them in a very safe place and make sure they're accounted. Communication with specialists should be documented on what level of pain meds they're doing. We've developed an EMR system that if another pain specialist is documenting that is giving pain meds, we come to know about it. And of course, pain contracts and any history of abuse and review of old contracts. So there's a lot of stuff to be done on it. But if you have a basic checklist for every patient who is on pain meds, then it makes your job easier. Just like we do it nowadays for our HEDIS criteria or MRA documentation, which is really about compliance. This is also part of compliance, and I think this is, in one way, it is painful, but it will make us sharper, and it will make us better physicians, at least as far as documentation is concerned. And I think it will make us much safer. And one more important thing, and I think today is the 27th, so we have 3 more days to register with the state for any physicians who is going to write any controlled substance, and I'm sure Vester will talk about it or has already talked about it. That's very easy to do and should be done ASAP.
Right, right. Okay, I'm going to go ahead and go to page 10 now, slide 3.3. If you are a board-certified anesthesiologist, a physiatrist, neurologist, or a surgeon, or you have another board accreditation in pain as described here, then you don't have to follow all these rules from 3.2. But I sure would anyway, or at least have your assistants document as much as you can. Then on page, go ahead.
Alan, before you move on, can you go back to the previous slide?
3.2, sure.
I want to, yeah, just make sure it's clear that items 1 through 9, the first bullet point there, those are generally existing requirements for prescription of pain medication that exists now for MDs and DOs. and nobody's exempt from those. The second bullet point are the standard of care requirements for those physicians who are registered. And there's a significant degree of overlap, but not entirely. So I just wanted to make sure it's clear that there are documentation requirements for any doctor who prescribes a controlled substance to treat pain in any circumstance. And that's what these items 1 through 9 are, I think.
Oh, thank you very much for correcting me on that. Okay. Then on page 11, we have where you go on the web to go ahead and register. And in the book that you also received today, we have more information on that, and we have even the exact web page pictured and all the information that you need to have with you when you set up to go to the website to register. Okay, now we're going to talk about what Lester just mentioned, and that is these long-standing administrative regulations that apply to physicians prescribing controlled substances for any kind of pain. So this would include the chronic non-malignant pain, or this would include the malignant pain as well. And in the book, we have the exact rules for MDs and the exact rules for DOs, and they're very similar. Primarily, you want to cover what you see here on page 12. Any comments on that, Lester or Dr. Singh?
No.
Okay. All right. Now, on page 13, something that's not going to apply to very many of you at all are the restrictions and exemptions on the ability to dispense controlled substances where you're basically getting paid. Now, you can dispense complementary packages of drugs known as samples if they're properly handled. But if you're going to be selling medications from your office, then you're going to have to meet the responsibilities that a pharmacy meets, and you're going to have the same type of inspections and the same types of obligations as pharmacies are having to meet. There is an exception for clinical trial. There's an exception for methadone facilities. There's an exception in the hospices, and there's an exception in the prisons and jails. But otherwise, if you're dispensing medications, you're going to need to be very careful to follow the rules and decide whether you're going to be a dispensing practitioner. And if so, it would be best to hire a consultant to come in to make sure you're going to follow the rules carefully, because they really want you to inventory and document what you're doing with these substances. Lester,
the new statute prohibits dispensing practitioners from dispensing Schedule 2 or 3 drugs, at all. So previously they could, but under the new statutes passed last year, as of I guess October 1st, or maybe that was July 1st, I don't recall, dispensing practitioners cannot dispense Schedule 2 or 3s.
Even as samples?
Other than samples, right. That was a big hit. I mean, it's a big part of how pain clinics make their money was through dispensing those drugs.
Okay. Lester, I'm going to go ahead and let you now describe the eForce program.
All right. The eForce, as it's called in Florida, is the Prescription Drug Monitoring Program. Is something that most states have had for some time. Florida is a relative latecomer. And as you may recall, Governor Scott really didn't like it, but nonetheless it went into law. This requires that dispensing practitioners and pharmacists report anytime a prescription is written for certain controlled substances for people 16 or older. This does not apply to physicians who merely prescribe controlled substances. There's no reporting that they have to do, nor does it apply to physicians who administer a controlled substance in their office. For example, an injection of something, or give somebody a pill to consume in their office. It only applies when drugs are being dispensed, and it then requires the dispenser to report. This is not optional. What is currently optional, although that may change, is that the physician's role, who's not a, if the physician, assuming the physician's not a dispensing practitioner, is they have the option to look at the database to see what their patients are up to, essentially. So, for example, I'll go back to my sprained ankle example. You have this person who is complaining of continuing pain, and you're a little concerned that they're drug shopping. You look at the database, and you might see that they've been to 4 other doctors in the past month, all of whom have prescribed pain medications to that patient. And that will make it clear to you that you're not prescribing anymore. And I've heard from physicians who were very surprised, who checked on patients in this database to find the patients were in fact doctor shopping, and they never would have guessed it. You know, if the patient didn't seem like the type. This is something that, although not required, I think it's going to quickly become the standard of care, that if you're prescribing a controlled substance for more than just a very brief acute episode, or you know, post-surgically for a limited period of time at least, that you in fact do check in this registry to find out if your patients are getting controlled substances from somebody else. Because then if you don't do it and you prescribe them and there's a problem, you're the last prescription that causes the overdose, and you haven't checked the database, it's just going to add to what are already going to be a lot of woes, but it's probably going to make it worse because you may have avoided writing that prescription had you checked the database. I think it'll become required, but who knows what the legislature will do. Right now it's not required. But as far as I'm concerned, you should consider it required. And this is what I was talking about earlier, that even if you say, I don't want to register, all of my patients I'm going to just consider to be in the usual course of illness or injury, they're still going to know, the state's still going to know what you're prescribing, because the database is going to collect that information, and part of the information that's collected is who the prescriber is. So, you know, your prescribing habits are going to be well known to the Department of Health, whether you register as a controlled substance prescriber or you don't. So that's another reason not to be afraid of registering if for some reason you otherwise are. But again, the main point here is you really should check it, the database, and you should document that you checked it and document that there was no other report of any prescribing, or if there was, why you're not prescribing the drug to the patient because of what you found in the database. And maybe even talk to the patient about it, and perhaps talk to them about an addiction problem, but you know, that's an individual decision. But that's the key point with the database. You really need to check it for those patients.
And Dr. Singh, is your organization checking the database? Have you had some experience with this yet?
Yes, actually we do check it. We were not using eForce earlier, and I believe it's actually even the pharmacists we have come to communicate with, because you know, each practice has some 5-6 pharmacists who work who prescribe, or who at least dispense almost 90 to 95% prescriptions for that practice. We have really tried to work with them very closely, and even pharmacists are checking these. In the old days, there was not such a good system, but now even our mid-levels and practitioners are able to access, if a patient is getting meds from other practitioners. So this is an excellent thing. I know it's going to be expensive and difficult and onerous, but I think it's going to make everyone safer and stronger, and basically creates the standard of practice.
It's going to keep patients from abusing the system too,
yeah.
Which is going to be good and interesting. Okay, why don't we go ahead and move on to registration and inspection requirements. I'm on page 24, section 7.1, and now we're going to talk about the pain clinics. Now this is completely different from whether you are prescribing a certain type of medication where you have to register individually. This is whether your practice is considered to be a pain clinic. And you are considered to be a pain clinic if either of the following 2 rules apply. Number 1, your practice advertises in any way for pain management services. Now, this could be a website, This could be your Facebook description. This could be a billboard. But if you have the word pain or something like that in any of your advertising, then you have to face these pain clinic rules. Secondly, in any month, the majority of patients are there for the treatment of chronic non-malignant pain. Now, that's going to be a much harder obligation to satisfy. But I think the advertising, I think we're going to have a lot of physician clients who are inadvertently advertising pain management because they've never even read their own website. So we want to be very careful there. Lester, do you want to take it from here?
All right, Alan. It's interesting to note that also a few months ago now, the Board of Medicine issued a declaratory statement responding to several scenarios that the Florida Medical Association had presented to them, asking whether or not in these different little scenarios or vignettes, the practice needed to register as a pain clinic. And it did things like, you know, had a sample of a yellow page ad or something at a web page or those sorts of things. And as Alan noted, you know, when the board, I mean, essentially if the word pain was anywhere, the board found that that would bring them into the classification of being a pain clinic and being required to register. So it is interpreted broadly. And you know, a lot of physicians believe this only applies to what are commonly known as pill mills, which might be the second half of the OR, where in the majority of a month patients are getting these drugs to treat chronic non-malignant pain. Remember now, these are not post-surgical patients, these are not cancer patients, etc. These are those patients that are, you know, fall outside of those categories. That, you know, that's one thing, but this advertising issue is going to potentially capture, or does capture, an awful lot of practices that would otherwise, under the second element, not have to register. So it's really important that you carefully look at all forms of advertising, and remember that forms of advertising include your web page, include your Facebook page, which a lot of people, you know, or any other social media page, which a lot of physicians have not in the past considered necessarily to be quote-unquote advertising. But in the eyes of the board, Department of Health, it certainly is advertising. So if you want to avoid registering as a pain clinic and you don't otherwise prescribe a lot of controlled substances, or you wouldn't meet the second part of the definition, you need to be very careful about the first part.
Okay, very good. Now, although you may be advertising for pain and you may be doing a lot of this, you may still not have to register as a pain clinic if you meet one of the exceptions on page 25. And that is where a majority of the physicians in the practice are surgeons, where the practice is wholly owned and operated by board-certified anesthesiologists, physiatrists, or neurologists. We've had a lot of clients where we have the husband and wife both own the practice, where one is the physician and one isn't. We've had to change that in order to keep the practices exempt from these pain clinic registration rules. Then you have the wholly owned and operated by board-certified specialists who have the pain fellowships, which you have to make sure that that's met. Of course, hospitals and ASCs are going to be exempted. Publicly held companies are going to be exempted. You know who has all the lobby power in Florida. Affiliation with an accredited medical school, or a clinic that does not prescribe controlled substances for the treatment of pain. So I guess an acupuncture clinic or an herbal type medicine situation would not have to register as a pain clinic. And then a community or a charitable organization would not have to register. There's proposed registration to add psychiatrists and rheumatologists to the list of accepted practices, but that hasn't happened yet. Lester, any comments on that?
Not specifically. I think one thing, just to sort of point out item F there, there are physicians, and I've run into this a couple or three times now, who do have some form of, quote, affiliation with the medical school. You know, their medical students or residents follow them around, you know, for a month, day to day in the office or whatnot under some form of an agreement with an accredited medical school. Arguably, those practices are affiliated. There's really no definition of affiliated. So, while that probably still doesn't account for a significant minority even of practices, there are physicians out there who do that and might fall under that exemption where they otherwise may not.
Okay, so with just 4 minutes remaining, I will mention that we have other pages here. If you are working in a pain management clinic, then you need to make sure that it has a designated physician, and you have to look at, they make the physicians responsible for everything. You have to even make sure that there's a proper signage, proper phone number, emergency lighting and communications, reception area. You have to make sure there's a working restroom. I mean, they really are doing everything they can to discourage physicians from being in non-board certified, non-exempted pain clinics. If you're in a pain clinic, I hope you're getting paid a lot of money and that you have all the resources you need to follow all these rules, because if somebody gets hurt in your pain clinic, you're going to be the one nailed with a malpractice suit. Lester, if you have any questions on that, let us know, and then we'll let Dr. Singh kind of sum it up for us.
No, I would just think twice if you're asked to be a designated physician, and if you are going to do it, you probably should let your malpractice carrier know, because it is going to create liability for you that you might not have otherwise have had. It's kind of a different kind of liability because it's not really treating patients, but yet you could be blamed for something that resulted from the actions of another physician because you didn't ensure that the clinic met all its requirements. So there is a lot of liability to going with that position.
Right. Okay, so Dr. Singh, we're going to let you sum it up for us. On page 34, I have your excellent memo on pain management compliance in the office. Just for everybody to see, it's there. On page 37, I also have Dr. Singh's compliance checklist, which is pages and pages of really good compliance items and ideas. So what do you have to say to us?
Well, a couple of things, and this is just, common mistakes we made. Let's talk about that, because really you have made a great summary and put everything together of a very complex law. But very quickly, one is I see a lot of advertising in the newspapers for, say, diabetes, hypertension, and you will see low back pain. A lot of these family physicians and internists are marketing, and they put and people will slip that in, and we don't even realize that is, I believe, comes under the purview of this law.
Sure does.
We should remove that low back pain, and any kind of other pain, we should take it out. Second is, which something is very important, is everybody in the practice should be using the safe prescriptions, and if more detail is needed, we'll be happy to provide. There are only few vendors or people who can print these prescriptions. Basically, they should be prescriptions which are according to certain standards. Also, how to write a prescription, and sometimes we see this. The prescription has to be legible, the date has to be written, the amount has to be written out. You can't just write a number, your signature has to be right. All those things are there, and this has to become a habit. More and more, in the old days, people used to, I remember when I started practicing, I never wrote my DEA number, and now pharmacists are returning it, and soon I think it will become mandatory. In the old days, they used to forgive you all these things, but I think we have to remember that these drugs can kill. And we've all had patients who have taken meds from us and other specialists and then overdosed and their livers are shot. And one of my youngest patients who died, 35-year-old, she got medications from 5 people, including me, and the Tylenol was so much high, she died. It was not an intentional overdose, but she took so much of these pain meds, it destroyed her liver. And all of us were in a shock. Now, and this is, these things, this is the school of hard knocks, and these things should not happen, should not have happened, but we've all been a part of it, and now is the time to take this, knowing how serious this is, now is the time to really get down to it and create a practice which meets certain standards and certain compliance processes, and we need to make sure we instill those processes in our practice. We have to really insist on it. I definitely recommend everybody having an EMR, electronic medical records, because reviewing your data at the end of the month is critical. How many prescriptions you're writing, what kind of prescriptions you're writing, which patients, communicating with your consultants, whether through EMR or through portals which are safe and secure, is critical. And reviewing your prescriptions and your other processes is absolutely important, because communication among physicians, which has been poor till now, has to be improved, and we must make sure that anybody who's working with us and other specialists, even in our geographic area, is either emailed or communicated with, that if we have a mutual patient, please send us a copy of your records. In the old days, we got by without getting those. We must have all the consultants' notes in our charts somehow or the other.
Oh, okay. Excellent.
There's so much to say on this, but we've run out of time, so I'll pass the baton back to you, Alan. We'll be happy to send any information to any physician who wants it and make this better for everyone.
Okay, so all the attendees, I want to thank you for joining us. I want to thank you for supporting our programs here and helping to get the word out. This webinar will be posted to our website at Gassman Law Associates tomorrow morning, so you can replay it or have your friends replay it, your colleagues. I want to thank Lester for participating during his vacation. I want to thank Dr. Singh for participating. We will be publishing the booklet you have today as a book. In about 3 weeks, it will be on Amazon, and then we will update it from time to time with the assistance of a great many Stetson Law students who have been very dedicated and have done a great job on this. So thanks, everyone. Now back to your families, and enjoy the rest of this holiday week.
Thanks, everyone. Have a happy New Year.
Thanks. Bye-bye.